Orthostatic intolerance, Part 2. The severity of autonomic symptoms can additionally be assessed by a COMPASS questionnaire, a validated set of 73 questions grouped into specific domains of autonomic dysfunction. Elevated COMPASS scores greater than 32.5 have been found to be a reliable diagnostic tool for the presence of autonomic dysfunction among those with ME/CFS. It is critical to understand that a finding of POTS, of hypotension, or of a narrowing of the pulse pressure are merely findings of measurable compensatory responses during the physiological challenge of upright positioning and are not specific diagnoses in their own right. Many who meet POTS criteria do not have ME/CFS, and many with ME/CFS and orthostatic intolerance do not display measurable heart rate and blood pressure changes with orthostatic challenge. In fact, a recent study measuring total transcranial blood flow with Doppler ultrasound upon orthostatic challenge found a 26% decrease in cerebral blood flow in ME/CFS patients, as compared to a cerebral blood flow reduction of only 7% in healthy controls. Most strikingly, though, was a finding of a 24% cerebral blood flow reduction in those with ME/CFS who did not meet criteria for major heart rate or blood pressure changes. It is thought that past perfusion studies performed by various imaging modalities have failed to detect these differences because they are performed in the supine and not upright position. The circulatory dysfunction and dysautonomia underlying orthostatic intolerance is one of the most modifiable aberrant physiologies in ME/CFS, and while treatment approaches are not always uniform, most people suffering from ME/CFS will note improvements in their fatigue, their hours of upright activity, and their quality of life as a result of treatment of orthostatic intolerance. Increasing intravascular volume, often by aggressively increasing intake of fluid and sodium, can have an enormous clinical impact. Mixtures of electrolyte rehydration packets dissolved within fluids can be sipped throughout the day and chugged in boluses prior to physical or cognitive exertional challenges. Fludrocortisone is often prescribed to assist with renal water and sodium retention. IV normal saline boluses are quite effective for both initiation of treatment and for rescue therapy among highly symptomatic or dehydrated patients. In the most disciplined of patients, desmopressin can drastically reduce water losses and increase peripheral vasoconstriction. External compression with compression clothing may prevent dependent venous pooling and increase venous return to the right atrium. The more surface area upon which compression can be applied, the more notable the clinical response. Pharmacological compression by alpha-1 agonists like midodrine can increase peripheral vascular resistance through constriction of arteries and veins. Off-label use of pyridostigmine can be life-changing for some with ME/CFS. This drug appears to increase systemic oxygen extraction in tissues, resulting in preganglionic acetylcholine stimulation of sympathetic ganglions innervating tissue arterioles with postganglionic fibers that result in tissue vasoconstriction and measurable increases in cardiac preload. Pyridostigmine also appears to increase parasympathetic inputs upon heart rate. Low doses of non-selective beta blockers like propranolol and bisoprolol may be used to reduce rapid heart rate responses and may also interfere with the binding of adrenergic autoantibodies now known to be present in those with ME/CFS. Beta blockers must be used with caution, however, as excessive heart rate suppression may inhibit compensatory heart rate increases intended to augment cardiac output for the support of physical or cognitive activities. The causes and mechanisms driving orthostatic intolerance and dysautonomia in ME/CFS remain poorly understood, though preliminary research has suggested potential contributions from all of the following. Autoantibodies directed at alpha and beta adrenergic receptors as well as at cholinergic muscarinic receptors. Anatomical mechanical disruption of autonomic fiber signaling within the brainstem and atlanto-occipital regions. Increased vascular compliance and mechanical stress upon vasculature within hypermobility syndromes. Excess mast cell activity. Impaired circulatory control caused by or resulting from mitochondrial dysfunction, and autonomic neural or perineural inflammation resulting from viral infection or reactivation. In summary, there is substantial evidence supporting the presence and enormous clinical impact of orthostatic intolerance in ME/CFS. orthostatic intolerance is both diagnosable and treatable and can significantly improve patients' activity tolerance, function, and quality of life.